Selamat siang rekan-rekan sejawat
Oh, baru
sekalian.
mulai. Oh.
Terima kasih atas kehadirannya kembali pada acara Jakarta Diabetes Meeting 2020. Terima kasih kepada para guru besar, senior, dan rekan sejawat sekalian yang masih menyempatkan waktunya pada sesi siang hari ini. Insya Allah kita masih ada beberapa sesi pada siang hari ini. Dan sesi siang hari ini akan dimulai dengan sesi Meet the Professor bersama Prof. Sidartawan Soegondo dengan judul materi adalah Fixed Ratio Injectables, The Role in Diabetes Treatment Continuum. Baik, untuk Prof. Sidartawan.
Ya.
Ya, terima kasih Prof. atas kehadirannya Prof. Silakan Prof. menyampaikan materinya.
Oke, terima kasih ke Dr. Wafa yang siang hari ini menjadi moderator saya, kehormatan. Dan tugas saya dalam acara ini adalah tentang injectables. Mari kita ikutin, setelah itu kita diskusi.
Iya, Prof.
Welcome to the Jakarta Diabetes Meeting. Dear colleagues, today my topic is going a little bit new. My talk is about fixed ratio injectables, the roles in diabetes treatment continuum. Just again, fixed ratio injectables. Today, my objectives are first discussing about the importance for early treatment intensification, and of course, glycemic control. And the next will be focusing on adult patients with type 2 diabetes who continue to struggle with an A1C more than 9%. And we hope that this 9% is already with oral agents. Thus, we have to look for the probability to achieve control, to achieve less than 7. But of course, with injectables, and we know that there is a poor probability to achieve this with a single injectable. Just the highlight is potential limitation associated with sequential treatment approach. I will going to talk about that. And at the end, discussing the potential benefits of initial combination therapy for type 2 diabetes to have appropriate target for these patients. Okay, let's start. We know that despite new therapies, many people with type 2 diabetes are not at goal. 50% of the people in the United States diagnosed with diabetes are not at target less than 7%. The same as in Europe. 50% of these people in Europe are not at target also. Approximately of 80% of adults in type 2 diabetes, according to IDMPS, this database, they are treated with premix and basal insulin, but they do not achieve also the glycemic control of less than 7%. Yeah, and the majority of individuals with type 2 diabetes in the developing world, we have the US, we have the Europe, and now let's all talk about developing countries. Achieving glycemic control is also a little bit difficult. You see here that there are unmet needs of this high A1C to achieve the target. Thus, we need further intensification. Look at this data. Distribution of A1C among adults with diabetes. The enhanced in the United States. You see, let us talk about more than 9%. 15.5% of people in the US between 1999 and 2014 has an A1C more than 9%. What about CDC, national report? Also, more than 9%, about 14.5%. What does this discovery study program tell us? Individuals with type 2 diabetes initiating second-line glucose-lowering therapy. You see that in Southeast Asia, 35.6, and in the Eastern Mediterranean, 33.9, they start initiating the second line to more than 9%. The magic word is mostly US, Europe, Mediterranean. Cutoff is more than 9% before they start to use single next drug. Yeah, and total 19 countries, more than 50%, 25%. This you see some 15%, some 25%, yeah, some 30%. But let's see. Let us talk about A1C more than 9%. Yeah, but what was the problem? We know we cannot achieve that because first, diabetes is a disease that causes because of hyperglycemia, but has a multi-pathophysiology cause. It affects the liver, the muscle, the pancreas, the fat tissues, even the brain, the intestines, the kidney, and then, of course, the pancreas. Multi-pathology. And because of that, you need also multiple therapies. Yeah, you need multiple therapies to target different pathophysiological abnormalities. Just only for hyperglycemia, because of so many pathophysiology, there are 8, yeah, some say are 12, but fine, there are many pathophysiology. And besides of that, achieving this glycemic control target is challenging. Why? Because there are barriers. There are different things that we have to do. Let us see this. Yeah, this is the stepwise. Yeah, this is the stepwise. Yeah, you start with monotherapy, dual therapy, combination. This is failure based. Yeah, substantial inertia exists at each stepwise intensification step. We wait until it fails and then we increase, or we look for another step. Because of that, there's also other challenges. There are barriers. Yeah, there are challenges to move to insulin therapy. What are the concerns? Physician concerns. There are concerns about insulin titration. There are concerns about adherence, about multimorbidity, and of course, adverse events. But what about the patients? The patients are afraid of hypoglycemia, of weight gain, regimen complexity, and in the US, retaining driver's license. Yeah, these are the clinical inertia and the barriers which cause, if we want to do next step to use insulin, there are these things. Yeah, and don't forget, when the A1C more than 9, the beta cell impairment is already there. If you see at this, yeah, relationship of the A1C and beta cell function in newly diagnosed drug-naive type 2 diabetes, yeah, 62%, 62% is already dysfunction A1C more than 9. You see here. Yeah, the 62% decline in beta cell function was seen at A1C more than 9%. And at the diagnosis, as we know, there's a 50 to 80% decline of beta cell function at diagnosis, but it will continue. It will reduce, yeah, between the first year and second year, it goes down. You see here. Yeah, after that, everything goes down. Beta cell, A1C9. This 9% has to be taken care of. The A1C, 9%, 62% of the beta cell function is already damaged. Yeah? Now, to achieve this, we know that we have to intensify the treatment. Treatment intensification may decrease the risk of cardiovascular events in patients with type 2 diabetes. Now, this is a study, yeah, A1C more than 7% and A1C more than 7.5% within 1 year and after 1 year. This retrospective observational study evaluating risk of CV events with delayed treatment intensification in type 2 diabetes, newly initiated with basal insulin. Early treatment intensification within 1 year post-basal insulin therapy was linked to 18% reduction in the risk of heart failure, myocardial infarction, and stroke. Yeah, this we have to intensify. if we want to reduce the risk of cardiovascular events. Okay, let's talk about the next topic. This is the focusing on the treatment and the struggle to achieve uh, less than 7% with patients with more than 9%. The study is about injectables. Injectables monotherapy plus oral antidiabetics may not get patients to goal. Yeah, just remember, monotherapy. This is a retrospective analysis. Yeah, despite robust A1C lowering following initiation, most patients on oral antidiabetic monotherapy fail to reach the goal, that's less than 7%, with GLP receptor agonists, basal insulin, or on 2 OADs. You see here, patient not at goal, 59% with GLP-1 receptor agonists, 53% with 2 OADs, and 67% with basal insulin. Yeah, doesn't meet the target. That means we have to do something. There are still other unmet needs. The single injectables with premix or with basal insulin. Approximately 80% of adults with type 2 diabetes treated with premix or basal insulin did not achieve adequate glycemic control. And the incidence of hypoglycemia was high, indicating that there is an unmet medical need to improve these clinical outcomes. You see here the statistics. The proportion of A1C less than 7% and the proportion of hypoglycemia in the past 3 months. That's single injectables, premix, and basal insulin. And also the low probability to achieve the less than 7.5% if you use this premix achieving control. Yeah? Now, again about single injectables. Yeah? GLP receptor agonists or basal insulin. Look at this. This one is the GLP-1, and the next one is basal insulin. Yeah, if you see here, the baseline between 7 and 8, 8 to 9, and more than 9. Yeah, for individuals with A1C more than 9%, the probability of achieving glycemic control with one injectable agent is low. In this population, the probability of achieving glycemic control was less than 20% within 1 year and less than 30% within 2 years in people treated with GLP-1 receptor agonists or basal insulin, single injectables. Only GLP-1 or only basal insulin. That's what do we have to do? Try to give them both. Now, I mean two. Yeah? This is a trial about simultaneous initiation of basal insulin and GLP-1 receptor agonists, which was more likely to get patients with high A1C to goal than sequential initiation. This is about simultaneous and sequential, at once or stepwise. Yeah? This you see here that simultaneous administration of a GLP-1 receptor agonist and basal insulin resulted in greater A1C reduction within 12 months, with more patients reaching the goal of less than 7%. Simultaneous and sequential, they achieve the goal, but the simultaneous, this both at once, has better results to achieve the A1C. Why do we have to combine? Combining injectable treatments modalities should be used earlier so that we can lower the A1C sooner. What does the ADA-ASD say? The ADA-ASD consensus statement states that the combination of basal insulin and GLP-1 receptor agonists has been potent glucose-lowering actions compared with intensified insulin regimens. And even also the AACE and ADA guidelines recommend that early combination therapy in patients with type 2 diabetes with A1C more than 9% or 1.5% to 2% above target, respectively, as the effectiveness of most oral medication rarely exceeds a 1% A1C reduction. Yeah, this you see. Yeah, it's rarely if you don't combine with reduce more than 1%. This GLP-1 receptor agonist and addresses both fasting plasma glucose and postprandial glucose in a single injection. And then we have to combine with basal insulin. Okay, what are the benefits of combination treatments in type 2 diabetes? They have a mechanistic synergy, they have complementary mode of action, multiple pathophysiological defects are being tackled, a greater potential for beta cell preservation, and also additive extra glycemic effects regarding energy balance and organ protection, CNS, heart vessels, and the kidney. What next? Hyperglycemia connection. This first one is the mechanistic synergy. The second is hyperglycemia correction. There are a greater efficacy of A1C reduction, concomitant targeting of fasting plasma glucose and postprandial plasma glucose. What are the clinical outcomes after mechanistic synergy, hyperglycemia correction? The clinical outcomes are greater potential for prevention of CV complications and nephropathy, lower risk of hypoglycemia, and more effective weight control, slower diabetes progression, and of course, improved adherence. The next is, let us discuss about this fixed ratio combination. Glargine plus GLP-1 receptor agonist, lexacenatide. We know that the ADA guidelines, there's a decision cycle. This, every patient, if you meet a patient, this decision cycle is patient-centered. Yeah, we have to start with this. Assess the key patient's characteristics first. After you know this, after that you consider specific factors which impact the choice of treatment. First, you look A1C. The second, you have target A1C. And after that, you share the decision making to create management plan. You know the A1C, you target the ANC. Now, let us decide together, make a plan. And then we agree to the management plan and then implement the management plan. And after that, we just need an ongoing monitoring and support. And at the end, of course, reviewing and agreeing on the management plans again after reviewing. This is the cycle of the 2020 ADA. And then after that, if we want to start treating, we look for glucose-lowering medication, as this ADA, ASD guidelines told us. Yeah, first-line therapy is metformin and comprehensive lifestyle. And then we look for indicators of high risk or established ICVD and CKD or heart failure. And then after that, considering independently of A1C baseline, our individual's target, we look for second drugs after metformin. But we know that 15 to 25% of patients with type 2 diabetes have ICVD, congestive heart failure, or CKD, but 15 to 25%. But there are other patients, 75%. Then this is different. If we don't have this, then we look for the other part. And we see if there's no ICVD, no CKD, then we have to look for drugs. Yeah. Then we have to individualize. The target will be A1C. Before, it doesn't depend on A1C. But here, we have to individualize the A1C. Yeah. Compelling need to minimize hypoglycemia, comparing need and minimizing weight gain, and of course the last is if cost is a problem. Yeah, this has to be a target. Okay, now we know that decision cycle. We started it. When we choose medication, we have the guidelines already. ICVD, heart failure, CKD. If we don't have it, then we have the next step. Yeah, but let's see. If we want to target A1C, we need to reduce the fasting and the postprandial. But with basal insulin alone may not address the multifaceted type 2 diabetes manifestations. Yeah, thus we know that if you want to achieve a target, wait for 3 months. A1C is 10. After 3 months, it's not achieved. You look for the second drug, and so on. After oral antidiabetics doesn't achieve the target, we have to do next step. And usually it is starting with basal insulin. We know that to achieve A1C, we have to have both. And this slide shows a study of Reader that postprandial and basal hyperglycemia, the total hyperglycemia has almost the same contribution of the fasting and postprandial to hyperglycemia. You see almost the blue one is the basal hyperglycemia and the green one is the postprandial hyperglycemia, almost the same. Thus we have to reduce both fasting and postprandial. Unlike basal insulin alone, the fixed ratio combination can help address the postprandial and the fasting challenges. Basal insulin is the most effective agent to lower fasting, but it is associated with hypo and weight gain. Therefore, we have to look for another way. Yeah, fixed ratio combination, a basal insulin and GLP-1 receptor agonist allow administration of both agents in a single daily injection, improving convenience. The GLP-1 receptor agonist can lower both fasting plasma glucose, postprandial glucose, without an intrinsic effect to cause hypoglycemia while promoting weight loss. Yeah? Yes. You see, this in the real world, this is a study, yeah? To combine, let's see. Real world evidence suggests that for individuals with the A1C more than 9%, the probability of achieving glycemic control with one injectable agent is low. Yeah, GLP-1 receptor agonist or basal insulin. The efficacy of GLP-1 receptor agonist and basal insulin has been established in numerous randomized controlled trials. Therapeutic intensification with either GLP-1 receptor agonist or basal insulin is more apt to achieve A1C less than 7% if started early, when A1C is lower than 8%. As A1C levels rise, however, either agent alone has a 50% or less chance of achieving glycemic control, suggesting that frequently more than one injectable agent is needed. Thus, this study provides real-world evidence in support of the recommendation of ADA-ASD consensus guidelines to consider initial injectable combination, GLP-1 receptor agonist plus basal insulin, or prandial or basal insulin if A1C is more than 10% or 2% above target. You see, this you need combination. Now, how to combine? You can do it stepwise. You can do it simultaneously. These are studies directly comparing the simultaneous and stepwise intensification using propensity score matching. Yeah, the Get Goal Duo 1 and the Lixilen O. Yeah, you see the Get Goal Duo 1 is type 2 diabetes patients uncontrolled on a more than 6 months basal insulin plus 1 to 3 oral antidiabetics, A1C 7 to 9%, and the mean plasma glucose is less than 100 milligram per deciliter. What about the Lixilen O? Type 2 diabetes receiving metformin plus minus additional OAD, and A1C is 7 to 9% if receiving 2 OADs, and 7.5 to 10% if receiving metformin alone. Yeah, this is a comparison about Igler-Lixi fixed ratio, yeah, Lixilen O, versus stepwise insulin glargine lixisenide get goal duo. That means the first one, the get goal, is the stepwise, and then the Igler-Lixi is the simultaneously. Thus they compare the stepwise and the simultaneously, the get goal duo and the Lixilen O. Yeah, the same as the get goal duo 2 and Lixilan L. This one is simultaneously and one is stepwise. Now, what are the results? Agar Lixi, the combination, was associated with a greater reduction in A1C than the stepwise addition of insulin glargine and lixisenatide in adults with type 2 diabetes, uncontrolled on OADs, uncontrolled with OAD. Yeah, you see here that the reduction in mean A1C from baseline is minus zero point 0.6, and the one that is comparing Lixilen O and Get Gold Duo, this the simultaneously and the stepwise. Yeah. What about achieving A1C? Lixilen O plus Get Gold Duo 1, the difference is 29%, achieving the target less than 7% at week 24. Combination, both are combination. The one is simultaneously, the other one is stepwise. This simultaneously is better. Yeah? What about the early treatment? Early treatment of Igler-Lixi provide greater reduction in fasting plasma glucose, postprandial glucose, body weight, comparing with stepwise intensification. These are the data. Yeah? This fasting plasma glucose is 12% less, postprandial is 9, yeah, and body weight 1.3. Body weight changed from baseline to week 24. Iglar Lixi plus Iglar plus Lixi. Both are the same drugs, but the one is giving stepwise, and the other one is giving simultaneously. Iglar Lixi. Let's see about other things. Iglar Lixi was associated with a greater reduction in A1C than the stepwise addition of Iglar plus Lixi in adults with uncontrolled basal insulin. The first one is about oral antidiabetics. This one is already using basal insulin. Yeah, reduction in mean A1C from baseline is also better. Yeah, with Lixilen, lixisenatide, yeah, Iglar-Lixi, and this is the Lixilen L because it started already with basal insulin, and also the same with achieving the A1C target 29% better. Yeah. Also about the fasting plasma glucose, postprandial blood glucose, and the body weight. As you see here, fasting plasma glucose, postprandial, and body weight, of course, the simultaneously is better than the stepwise. Let's go along. What about early treatment? Early treatment of Iglar-Lixi was associated with no increase in hypoglycemia and lower rates of GI attacks. Yeah, we always say that adverse events, yeah, diarrhea, nausea, and vomiting, yeah, almost the same you see here. But as we see about the patients with events of hypoglycemia, the Lixilen O and the Lixilen L, you see, if you give it with combination, it's less than if you give it alone. Because if there is glargine, there's more hypo. But if you have Lixi, there's no hypo. If you combine, you will get less. Yeah? Okay, okay. After all what we heard there, now let's see what we can do. What are the clinical outcomes of this fixed ratio combination in people with type 2 diabetes? Let's start with this example. This Mr. Helan is insulin naive, uncontrolled with oral antidiabetics. He's 56 years old, man, diabetes for 8 years, body mass index 32 kg per millimeter square, millimeter square. A1C is 8.2%. He's already using metformin, SU, and DPP-4, and his concern is now weight gain and fear of hypo. This insulin knife changing in glycemic control. For this patient, yeah, he is only on OADs. This insulin knife, this study Lixilen O, yeah, if you see here, yeah, combining the Igler Lixi, Igler or Lixi alone, then you see here, let me show you it, yeah, this one, the blue one, yeah, Igler Lixi, the blue one you see here, A1C 6.5, the combination is 6.8, And the green one, if Lixi alone, is 7.3%. Yeah? You see, if you combine, you have it better. Yeah? This is also glycemic outcome, Lixi, with A1C more than 9%, proportion of patients reaching the target. This is also a comparison. Yeah? You see here, all patients with baseline A1C more than 9. The purple one is Igler, and this one is Lixi, and you see that the post hoc analysis is better. And what about the time to glycemic control? Yeah, for patients on Lixilen-O with baseline more than 7%, 50% of patients achieving their glycemic target and approximately half the time with Lixi versus glargine. This means if you combine, you get time to control is earlier, 85 days. Yeah, but if you use glargine alone, 166 days. Yeah, this time to first achieving the target less than 7%. What about body weight? Also the same, change in body weight, rates in hypoglycemia and GI adverse events. Of course, that is better. Yeah, let us start. Thus, the word is that if you are on ORD, oral antidiabetics, fail, you can use this aglylic straight away. Yeah, if you are afraid of hypo, and you would want to increase body weight. Yeah, that means let's see what we should do with this Mr. Helan. Yeah, this discontinued SU. This Mr. Helan has already on metformin, SU, and DPP4. Yeah, if we use this Igler-Rixi, we start with 10 units. Prior to breakfast, metformin we just continue, but we discontinue the SU, sulfonylurea, and DPP4. And we just initiate the Igler-Rixi. Yeah, and then of course we have instruction on self-monitoring of blood glucose and asked to monitor the fasting plasma glucose daily. Consult about the symptoms and treatment of hypos and potential for GI side effects of the GLP-1. Igler-Rixi is titrated once weekly based on the target of fasting plasma glucose less than 100 milligrams per deciliter. At 3 months follow-up, the Igler-Rixi dose is 26 units. The fasting plasma glucose is around 108 to 126, and the A1C is 7.5. There's a 0.8% reduction. Initially, experienced mild nausea that was resolved spontaneously within 2 weeks because we increased the GLP-1 step by step. No hyperglycemia and approximately 1 kg reduction in body weight, and increased Igler-Rixi dose to 28 units per day, resume weekly titration. We just continue weekly titration. And at 6 months follow-up, the A1C was 6.9%. That means there's 1.3 reduction in A1C and stable body weight and without complaints. This is about Mr. Helan, insulin knife on control. Let's see what we do. We start with this insulin knife person. We start with 10 units. The initial dose in insulin knife patients is 10 units. Yeah, we use this peach pen. Yeah, difficult to pronounce, peach and olive. Yeah, I also almost yellow. Okay, fine, peach. This pen, we have 2 pens, the peach pen and the olive pen. The 10 to 40 units pen, yeah, is the peach pen. We start with 10 units. We just increase it, yeah, weekly. If we increase and we need more than 40 units, then we have to change the pen. We choose this pen. Yeah, this pen is 30 to 60 units. Yeah, the ratio is 3 to 1, and then we increase the dose also until we achieve the target. So there are 2 pens, the olive pen and the peach pen. Yeah, okay. This is the peach, and this is the olive. Yeah, almost green, fine. Yeah, but you have to there are 2 pens. Okay, this potential patient cases for fixed ratio combination, we just go now for another case. Changes in glycemic control result from Lixilen L. Yeah, this also already with basal insulin. Iglaric-C was superior to Iglar for change in A1C. Yeah, we go fast with this. Yeah, patient achieving A1C 7% and time to glycemic control. Yeah, you see Iglaric-C and Iglar. Yeah, 35.5% difference, and also and 153 days. It is also time to achieve the A1C less than 7%. Also the change in body weight and rates of hypoglycemia. You see here, yeah, change in body weight comparing. The difference is minus 1.4, and also the symptomatic hypoglycemia. Yeah, comparing Iglaric-C and Raji. Yeah, let's see about the fixed ratio combination glycemic outcomes. Yeah, here we see that in the Lixilan L study, patients treated with Iglaric-C saw greater reduction in A1C compared with patients treated with Iglar irrespective of baseline. Yeah, this study will explain to us that any A1C, if you use Iglar-Lixi comparing with Iglar also or Glargine alone, at any A1C, there will be better results. Yeah? Let's start with the next case, Mrs. Maria. This patient is uncontrolled on basal insulin. The first one is only on oral antidiabetics, no insulin yet. This patient has already OAD and also using basal insulin. This 45-year-old woman currently on basal insulin 32 units per day and oral regimen metformin SGLT2 inhibitors, diabetes diagnosed for 40 years, body mass index 30 kgs, and A1C is 7.9%. The fasting plasma glucose was already 108 to 126 at range. But the postprandial plasma glucose frequently is more than 250. And this patient is very concerned about weight gain. The body mass index is already 30, already on basal insulin, but the prandial are still high. Thus, what should we do with this patient? Stop basal insulin and initiate this fixed ratio combination, Iglaric-C. Yeah, this patient has already basal insulin 32 units, but if we start, then we use 30 units daily prior to lunch. Yeah, continue the metformin and SGLT2. Receive info. This you have to give check the fasting plasma glucose also. Explain about the symptoms of hypoglycemia and also the potential side effects of gastrointestinal side effects of the lixisenatide. Yeah, there are some problems in that, but you titrate it twice weekly based on the fasting glucose target of less than 100. And at 3 months follow-up, Iglaric-C dose was 38 units. Fasting plasma glucose is less, around 100 and 108. And the range of A1C, A1C is 6.7. There's a reduction of 1.1%. There's no GI side effects, no hypoglycemia, and the body weight is stable. This patient continued with 38 units of glargine daily, the same oral agents, and follow up for next 3 months. Yeah, and no weight gain. How to start? We know that this patient is already on basal insulin. High. Yeah, this initial dose of subsequent dose titration and patient suboptimally controlled on basal insulin less than 30 units. Yeah, if less than 30 units, this patient is more, but let's say if less than 30, you start with 20 units. The initial dose is 20 units, the starting dose, you use the pitch pen, and then just increase, yeah, stepwise. And then if you need more than 40 units, you change the pen with this olive pen and just go on. Yeah, if this patient has basal insulin less than 30 units. But this patient has more than 30 units. This initial dose straight away with this pen. Yeah, this pen. 30 to 60 pens, 3:1 ratio, and just increase the dose. Yeah, until the target is achieved. Yeah, okay, that's one practical, the practical things. What are the benefits? Benefits of this fixed ratio combination. There should be benefits. Okay, let us talk about overall fixed ratio combination. Yeah, we use it to improve glycemic control for patients on control insufficient control with type 2 diabetes. There are two fixed ratio combinations, the iGlycine, the ideclira. The one is glargine 100 with lixisenatide. The other one is degludec with liraglutide. Both, if you see that the indication is for the treatment of adults with insufficiently controlled type 2 diabetes to improve glycemic control as an adjunct to diet, exercise, in addition to metformin with or without SGLT2 inhibitors. What about ideclira? Almost the same. Also indicated for the treatment of adults with insufficient control of type 2 diabetes to improve glycemic control as an adjunct to diet and exercise, and in addition to other oral medication products for the treatment of diabetes, almost the same. That is fixture ratio combination. Yeah. Now, how to select? Selecting the population to benefit from this for this fixed ratio. Yeah. Thus, we know that fixed ratio combination is appropriate for adults. The ADASD guidelines reflect the role of the FRCs as an intensification option for those already on GLP-1 receptor agonists and basal insulin, as an intensification of therapy for individuals who fail to achieve target using a single therapy, basal insulin or GLP-1 receptor agonist. What are the other factors that should be taken account also? Managing patients' expectations regarding expected side effects can help maximize adherence and reduce discontinuation. We know that each drug has side effects. But if you combine, you have less side effects. That means you can maximize adherence and reducing discontinuation. Following initiation, it is recommended to optimize glycemic control via dose adjustments based on fasting plasma glucose and, of course, after that, individual needs. Education is paramount to ensure proper use and to optimize outcomes. Of course, education is important. Now the problem is still about simultaneously or sequentially. We know combination is better, potential role of fixed ratio versus the treatment approaches. Yeah, this initial injectables with basal insulin and GLP receptor agonist is recommended in individuals with A1C more than 10% or in those 2% above target. Okay, we know about it. Patient groups for which fixed ratio combinations may be the optimal approach, patients concerned about weight gain with insulin, and those with high postprandial plasma glucose. Yeah, there is a real-world evidence study, the REACH-NET, that simultaneous initiation of basal insulin plus GLP receptor agonist significantly better glycemic control than sequential of basal insulin and GLP-1 receptor agonists. Statistically significant more patient in cohort 1 simultaneous than cohort 3 initiation beyond 90 days, achieving A1C less than 77%. This is again about simultaneous and stepwise. Yeah, if you start to initiate iGlycine, then you have to discontinue concomitant OADs. Basal insulin or GLP-1 receptor agonist or oral glucose lowering medication other than metformin and SGLT2 inhibitors should be discontinued. This we can retain metformin and SGLT2 inhibitors, but the others should be discontinued prior to the initiation of iGlycine. What about optimal time for daily administration? Iglycerine can be administered with any meal according to the patient preference. You just ask the patient where is his biggest meal, where does he wants to use this new drug with the meals. Once the patient determines the preferred meal, iglycerine should be injected once a day within 1 hour prior to the meal. Experts suggest considering the patient lifestyle and preferred main meal, of course. Yeah. And of course, for patients who discontinued previous GLP-1 receptor agonists due to GI side effects, gradual increase in GLP-1 receptor agonist dose when using iglycerine may mitigate the risk of GI effects. That's what means. If before there are side effects, if you use this iglycerine, the side effects are less, then you can start with it. Because if you intensify, it will up titrating very smooth, and the side effects will be less. Yeah? Okay. How to start? The recommended starting dose of patients prior to therapy. We know there are patients which are oral already. We know patients that are already on glargine and 20 to 30 units, but we know that some patients who have higher dose. This, if this patient is on oral antidiabetic treatment, you start with 10 units. You start with the pitch one, and then if the patient using basal insulin between 20 to 30, you start with 20. Although the patient, let's say, use basal insulin 25 or 26, you start with 20. And then increase stepwise. You still use the pitch one. Yeah? But if the patient are already on basal insulin between 30 to 60 units, then you start with 30, but you should use a different pen, the olive pen, iglycerine 30 to 60. Yeah? This is to be used if you start with 30 and the patient is on glargine between 30 to 60 units. Yeah? This, let's see. For twice daily basal insulin or glargine 300 units, the total daily dose previously used should be reduced by 20% to choose the iglycerine starting dose. For any other basal insulins, the same rule as for glargine 100 units should be applied, and the maximum daily dose is 60 dose steps. Insulin glargine, yeah, don't go higher than 60. Yeah? Okay, let's go next. Okay, summary. Dear colleagues, despite achieving their glycemic control, glycemic goals, and a lack of control may lead to complications, advances in therapy for type 2 diabetes. Many people are not at target. Early achievement of sustained glycemic control is a key component of effective management of type 2 diabetes. Therefore, there is a paradigm shift toward personalized early intensification with combination therapy could help these people with type 2 diabetes to achieve their goals. Combining the pharmacological properties of basal insulin and GLP receptor agonists can help to optimize management of type 2 diabetes, particularly in case of high A1C. The safety and efficacy of iglycerine has been demonstrated in adults with type 2 diabetes. And also real-world data indicate that simultaneously initiation of basal insulin and GLP-1 receptor agonists may help achieve glycemic control more effectively than sequential initiation. These findings help support the approach of using titratable fixed ratio combinations to simplify and intensify treatment in challenging patient population with long-standing type 2 diabetes. Dear colleagues, this is the end of my talk. Thank you very much for listening, and let's discuss.
Very nice talk, Prof. Sidartawan. Thank you so much. Terima kasih banyak, Prof. Subhanallah, banyak sekali yang kami dapatkan, Prof, dari kuliah Prof tadi. Mungkin untuk di sesi diskusi kita dalam bahasa Indonesia ya, Prof, supaya
Boleh.
memudahkan rekan-rekan peserta untuk bertanya. Langsung saja, mungkin Prof ini sudah banyak pertanyaan, Prof. Pertama dari Dr. Anton Wijaya. Mohon pendapat dari Prof nih, Prof, mengenai inisiasi pasien dengan yang sudah dalam inisiasi menggunakan co-formulation dengan IDEC-AS, Prof, pada pasien type 2 DM naif dengan A1C lebih dari 10% tanpa OAD sebelumnya, regardless tanpa mempertimbangkan CVOT atau tidak dan tanpa mempertimbangkan konsensus yang lainnya, dan pasien tidak ada kekhawatiran, tidak ada halangan terhadap injeksi. Mohon pandangan dari Prof. Ini mengenai co-formulation dengan IDEC-AS, Prof, tapi bukan tentang Aeglarix ini, Prof.
Oke. Ya, ini ada sedikit perbedaan ya.
Beda,
Jadi,
Prof, ya.
Oke, Dr. Anton, gini. Jadi memang kalau kita lihat kan kita bicara tentang A1C lebih dari 10%, sudah pakai co-formulation yang lain, ya. Tetapi memang tidak pakai obat oral, ya. Kalau tidak memberikan CVOT ada atau tidak, ya. Memang perbedaannya AS adalah dua-duanya insulin, ya. Sedangkan Aeglarix adalah insulin plus GLP-1 receptor agonis, ya. Nah, sebetulnya GLP-1 receptor agonis yang short acting dengan aspart mirip-mirip, ya. Dua-duanya untuk prandial. Bedanya yang satu ada insulin dengan risiko hipo, yang satu adalah GLP-1 receptor agonis dengan tidak ada risiko hipo. Risiko hiponya adalah di basal. Nah, basal insulin di Aeglarix adalah glargine 100, sedangkan di IDEC-AS adalah degludec. Ya, sama-sama basal. Ya, sebetulnya kalau kita lihat maka pertanyaannya ini bisa dikasih dua-dua, cuma ada perbedaannya karena yang satu diberikan satu kali, bisa juga masing-masing bisa satu kali. Ya, perbedaannya adalah nanti yang satu mungkin risiko hiponya sedikit lebih besar, tapi memang yang dipantau tetap adalah fasting. Ya, jadi kalau coba saya lihat initiation of using co-formulation, ya sebetulnya maksudnya mungkin yang Aeglarix ya. Tapi kalau saya lihat ini dua-duanya masih sama ya. Bedanya adalah yang satu adalah kombinasi antara glargine dengan lixisenatide, yaitu short acting GLP-1 receptor agonist, bedanya dengan lira yang long acting. Sedangkan yang IDEC-AS adalah degludec dengan short acting atau fast acting insulin. Ya, diberikan juga cuma satu kali. Kalau yang diandalkan di IDEC adalah basal yang stabil, sedangkan kalau yang di ini juga basal juga, tapi dengan 100 unit. Ya, jadi kalau diberikan biasanya kalau Aeglarix diberikannya satu kali. Ya, cuma bedanya kalau Aeglarix diberikannya kalau tadinya pakai glargine malam hari, maka Aeglarix diberikan pagi hari. Karena pada breakfast diberikannya karena mau mengambil prandial yang pagi. Ya, sedangkan kalau IDEC-AS diberikannya malam hari waktu dinner. Ya, beda-beda tipis. Yang satu, tinggal kita masing-masing pasien tentu ada pilihannya. Ya, dan kalau kita lihat, memang dua-duanya bermaksud untuk mengurangi jumlah suntikan. Ya, ya, dan monitoring yang lebih sederhana, lalu kemudian adherence yang lebih baik, ya, dan juga mencapai, dua-duanya mau mencapai fasting dan prandial. Mungkin itu dulu.
Baik. Baik, terima kasih Prof. Menyambung pernyataan dari Prof tadi mengenai pemberiannya pagi ya Prof, terkait dengan kita kan biasa berikan pada prandial yang banyak mungkin ya Prof makannya. Kalau
Ya.
pada orang Indonesia nih biasanya kan makannya memang banyak pagi, siang, sore nih banyak Prof. Baiknya pemberiannya gimana ya Prof? Apakah tetap pagi atau bagaimana Prof baiknya?
Jadi gini, yang pagi itu kalau baru, ya tapi biasanya kita tanya meals yang paling besar yang mana, ya. Ya tapi kalau misalnya dia tadinya udah pakai basal, maka dari basal bukan naik, udah pakai basal kita pilih ke pagi. Ya tapi kalau misalnya belum pakai apa-apa, kita tanya meals yang paling besar. Bius yang paling besar mana diberikan 1 jam sebelum dia makan. Nah, tinggal kita tanya, Anda makan yang paling banyak mana? Nah, yang susah kalau makan besar 3 kali. Nah, ya, jadi ini kan masing-masing pasien, jadi lifestyle-nya beda-beda, makannya beda-beda.
Ya,
Jadi
Prof.
kita lihat practitioner preference. Ya, nanti kalau yang pertama bisa tidak berhasil, baru pakai dosis yang kedua, baru kita lihat dosis yang paling kedua. Ya, tapi pada prinsipnya adalah ingin mengurangi jumlah suntikan dan juga risiko hipo. Ya, bedanya adalah kalau IDX adalah dua-duanya insulin, sedangkan Aglarixi adalah satu GLP-1 yang short acting. Masing-masing untuk prandial, masing-masing untuk basal.
Ya, Prof. Prof, misalnya kita berikan pagi pasiennya, kemudian dia masih mengalami postprandial siang, Prof, hyperglycemia postprandial yang lunch, Prof. Apakah kita dapat berikan prandial siang atau mungkin OAD seperti di BP4 siang hari, Prof?
Ya, tergantung dari awalnya ada pakai OAD atau tidak kan. Kalau
Ya,
sebenarnya
Prof.
pakai OAD, kita jangan tambah. Ya, ada perbedaan antara kalau naik sama sudah pakai obat.
Tidak,
Ya, nah itulah yang nanti bukan mempersulit. Harus kita betul-betul kontrol dengan baik. Tapi pada prinsipnya yang dikontrol itu tetap yang fasting. Kalau
pasti.
menaikkan dosis tetap yang fasting. Karena perandialnya itu praktis tidak hipo, ya. Dan juga dikatakan kalau kita mulai pakai Glarixi kan kalau kita pakai ICU harus di stop. Karena kalau nggak ada efek hiponya, ya. Jadi tetap kita hanya kasih, apalagi kalau kita, lalu demikian juga kalau masih pakai DPP-4 inhibitor juga di stop. Kan di dalam Glarixi ada GLP-1 receptor agonis yang juga incretin. Ya, jadi nggak bisa ada dua-dua. Jadi memang yang dipantau adalah yang fasting, yang prandial kita agak lebih tenang. Kalau fasting udah bagus A1C belum tercapai, baru kita bicara prandial. Nah, prandialnya itu nanti kita mau pakai dosis apa kita bisa lihat.
Baik, Prof. Kita lanjut ke pertanyaan berikutnya. Ini dari Dr. Teddy Jaya Ateng, Prof. Mana yang terbaik antara pemberian regular insulin plus basal dengan GLP-1 plus basal, Prof? Jadi mungkin basal plus dan basal GLP-1, Prof.
Ya. Jadi kita lihat dulu ya. Soal kita tidak bisa bilang mana lebih baik, mana lebih jelek. Pasien yang Anda hadapi yang seperti apa. Ya, tentu kalau kita berikan regular insulin plus basal, dua-dua insulin tetap ada risiko berat badan naik dan risiko hipo. Ya, sedangkan kalau kita kasih basal plus GLP-1 reseptor agonis yang short acting, risiko hiponya hanya ada di basal atau di akibat insulin yang rajinnya. Sedangkan yang Alexinya tidak. Kalau regular insulin dan basal kita monitornya lebih ketat. Nggak bisa hanya seperti saya katakan tadi. Ini kan kontrolnya hanya fasting. Kalau kita pakai regular insulin plus basal itu 4 kali, 7 kali. Kalau pakai multidose. Ya, bedanya adalah monitoring, adherence, risiko hipo. Ya.
Dan weight gain, Prof, weight gain lebih netral ya, Prof ya. Resiko weight gain-nya mungkin ya, Prof, yang beda juga ya. Ya, baik, kita ke pertanyaan ketiga, silakan. Ini tidak ada namanya nih, Prof. Bila pasien sudah mendapatkan insulin premix 2 kali 60 unit, apakah bisa diberikan 1 kali Aglarixi dan 1 kali tetap premix, Prof? Menarik nih, Prof.
Ya. Kalau kita lihat tadi, dosis maksimumnya 60. Kalau sudah lebih dari 60, jangan diomongin lagi. Ya, ini kan udah 2 kali 60, wah janganlah. Ya, artinya pengalamannya dikatakan kalau kita naikkan dosis, kalau sampai di atas 60, think of other ways. Jangan dipaksa pakai Aglarixi. Ya, karena dosis 2 kali 60 itu lumayan tinggi dosisnya. Dan kalau belum tercapai, saya sih terus terang bisa pakai cara lain. Karena premix 2 kali 60 itu monitornya susah. Monitornya susah. Ya, memang ada beberapa cara lain, bisa pakai multidose juga lebih susah. Ya, tapi kan lebih aman. Saya sih tidak gitu pro premix yang 2 kali 60. Saya nggak yakin bisa dikontrol. Malah mungkin harus lebih dikontrol lebih baik, mungkin dosis lebih kecil. Karena kalau 2 dosis sama itu jarang, biasanya dosisnya besar kecil, pagi dan sore. Ya, Tapi oke, pada prinsipnya kalau udah 2 kali 60, sedangkan dosis dikatakan oleh pakai Iglarixin lebih dari 60, don't increase. Ya.
Iya.
Memang
Mungkin
tadi pertanyaannya kalau kasih 60 terus pakai premix yang 60. Ya kenapa
ya
mesti
jadi di
begitu?
split Prof. Split
Kalau
Prof. Mungkin yang paginya ubah ke Eglar Lixi Prof. Jadi
iya
di
sih.
split.
Ya, bisa saja sih.
Tapi mungkin kita perlu pertimbangkan faktor yang lain ya Prof.
Ya.
Terkait dengan dosis sudah tinggi tapi belum tercapai kendali glisemiknya ya Prof. Baik Prof, menarik sekali. Namun sayangnya waktunya sudah habis nih Prof.
Ya, terima kasih.
Baik, terima kasih banyak rekan-rekan sejawat sekalian. Mungkin kalau bisa sedikit saya simpulkan bahwa memang pemberian terapi combination injectable dengan sedini mungkin ya Prof, itu
Ya.
memberikan outcome baik itu kendali glikemik dan juga cardiovascular event jangka panjang pada pasien dibandingkan dengan pemberiannya secara sekuensial ya Prof ya. Dan memang pemberiannya tentu personalized, individualized tergantung kondisi pasien masing-masing. Dan dengan pemberian Aigralixi ini memberikan benefit terutama pada weight gain yang lebih rendah resikonya, risiko hipoglikemia lebih rendah dan juga tentu pasien monitoringnya juga lebih mudah ya Prof. Baik, terima kasih banyak Prof. Sidartawan atas kuliah yang sangat menarik. Semoga bermanfaat banyak bagi para peserta. Demikian, saya kira saya harus tutup sesi kali ini, Prof. Terima kasih banyak, Prof. Sidar. Terima kasih banyak rekan-rekan peserta sekalian. Assalamualaikum warahmatullahi wabarakatuh.
Terima kasih Dr.
Terima
Wafa.
kasih,
Very
Prof.
good. Very much.
Thank you, Prof.
Udah, Don.